So our third keynote speaker, we wanted to hear from an expert, somebody who spends all of his day looking into the future. We thought it's really important to look at what the opportunities and the pitfalls might be into the future. And Farid from Merck Sharp Dome has a fantastic job title. He leads on world-leading evidence generation, which I think sounds fantastic. So he's going to talk to us about his perspective on the world, the future, the use of digital health to help patient outcomes. And so over to you, Farid. Thank you.
Thank you, Harry. So good morning, everyone. A little bit like Nick, really, in the fact that, I guess, Nick, I've got 3 children, so, I would do anything for them, so I congratulate you for what you've done. I want to look at my nan. So my nan passed away from lung cancer in February this year. And I guess, with hindsight, what I'd like to do is look back and say, if we fast forward, we put her in a time machine, could her outcomes be different? And what I really want to look at is I want to just change tack. I want to look at digital health. I want to look at technology-enabled care, big data analytics. Because for all of us that are developing medicines for rare diseases or in the biopharmaceutical space, I truly believe that digital health is disruptive. Okay, it will erode pharmaceutical margins, and actually, if adopted by healthcare, can really transform the way we deliver healthcare. So, how many people in the audience have a smartphone? Hands up. Okay, there's somebody with a brick over there. They now have a smartphone. In fact, as of this year, 50% of the global population have a smartphone. And in fact, if you look at the African continent, they actually use smartphone technology, digital technology, to actually reach a broader population. Who has an Apple Watch? Anyone? No? No Apple Watch? Fitbit, wearables? Okay. Did your GP prescribe you your Fitbit, your wearable? No? No. So the digital health is very much consumer driven, okay? But what I want to look at really is that how can practitioners adopt that technology? So what I want to do is I want to walk you through my nan's life history. So she was born in 1935. She tells me loads of great stories about the war. By the time she was 30, she had 7 children. She had 2 sons, 4 daughters. And in fact, I'm one of 26 grandchildren. I'm the eldest. By 1983, she'd retired. Yeah, so about 48, 47, she'd retired. So she used to work at Manchester Airport, not too far down the road from Liverpool. And essentially, she was a glamorous lady. She worked for BA. She was a bit of a trolley dolly in a day. But she was wonderful. But she took early retirement, and the main reason she took early retirement was that my mum's a hairdresser. And actually, she took early retirement so she could look after me, she could look after my sister. And unfortunately, 2 years later, she was diagnosed with breast cancer. And really this, for me, when I look back, and I was thinking about this really is the kind of turning point in terms of in my nan's life. So she was diagnosed with breast cancer, she had a single mastectomy, and she was put on tamoxifen. Then she pretty much stayed away from healthcare. So, we don't, today, if you're a patient at the NHS, you have annual, checks. Your GPs have a QOF register. They get points for, making sure you see them. So, but my nan really didn't have any interaction with healthcare up until 2012 when she had a fall and she was in hospital for 3 weeks. Then we fast forward to November. So she was, she's always, she had no mental impairment. Her faculties are always been there. But she was complaining. She had a bit of a urine infection. She was a bit confused. It was a bit strange for my nan. Underneath that, my nan's smoked for literally 65 years. Yeah, Benson and Hedges. Yeah, pretty much killed her. But she used to smoke 20 a day, right? And after the fact that she was diagnosed with breast cancer, what we saw was this glamorous lady become more sedentary. She had arthritic knees. She put on a lot of weight. In fact, she became morbidly obese. Yeah, she was about 20 stone. She had a huge BMI. I suspected COPD around about 2000. And after a fall, she pretty much gave up. She was bedbound, yeah? So her activity totally decreased. So that's my nan. So what could have been done different? So I'm going to put her in a time machine, yeah? She's still with us. What could have been done different? Well, if we think about digital health, so there's on the App Store, there's around about 100,000 apps for healthcare, yeah? Some of them, only about 5% of them are used in any kind of degree. Similarly, if you think about when you're on Facebook or you're on Hotmail and you get all these notifications, you think, why are they pushing all that information at me? Well, in the same way, how do we push, where the nearest smoking cessation service is in the local area? Yeah, we know the IP address, we know the location. How can we push behavioural messaging to those patients? So I think there can be a lot more, really light touch. So now, my nan was diagnosed with breast cancer. She had a mastectomy and she was put on tamoxifen. Let's say that tamoxifen had the Proteus ingestible sensor. Has anyone heard of Proteus? Okay, it's quite a few people. Good. So Proteus is an ingestible sensor. Essentially, what it picks up is, really when I worked at AstraZeneca, it was sold to us like, well, it'll be able to tell you when patients take a pill. Great for adherence. But actually, didn't really sell to us that it was great for adherence. Actually, what they started to look at, actually, it looks at physiological change. So you can understand whether patients are sitting, whether they're standing, when they're sleeping, when they're actually taking the pill. And actually, I'll put it to you that actually, if the ingestible sensor was in tamoxifen, that you would have seen a big change in my nan. So, what you're seeing here, this is Proteus, this is what it can sense it. So you've got the circadian pattern, so you can see approximately about 8 o'clock. My nan would have got up, actually a bit early, probably about 7 o'clock, yeah? And then you see all this raft of activity. And in fact, when she was diagnosed with cancer and she'd had a single mastectomy, she was still looking after me, she was still looking after my sister, we'd go shopping, we'd go to the park, yeah? We'd go to Blackpool and go on donkey rides. So actually, she was very active. Actually, as we went to school, yeah, she became less active. And this is probably what you saw. You basically see her becoming more sedentary in terms of her lifestyle, yeah? A little bit less motivated. Her adherence patterns on the left-hand side in terms of taking medicines would have changed. Now, I put it to you that if this dashboard was being monitored by a GP or a physician in the hospital or in the community, or even by me or my mum on an app, yeah, we would have seen this drastic change. And we would have, well, why is that change? Well, actually, she wasn't motivated anymore, yeah? She'd lost all confidence because of a single mastectomy. And actually, she didn't have anyone to really live for anymore. Her grandchildren had, gone to school. We weren't, she wasn't needed that much. She didn't go out and socialise. So actually, what she turned to is she turned from cooking the most amazing roast dinner to going towards, convenience food. She stopped going to the shops. And literally, that had a massive impact in terms of her weight and her obesity. So, this doesn't tell the full story. But then I put it to you, well, actually, if you think about when we do clinical trials, we collect patient-reported outcomes, we collect health quality-related data in terms of life data on patients. But actually, when we go to market, yeah, when do we do phase 4 trials or prospective trials collecting PROs, yeah, in a real-world situation? We don't. But let's say we did. Yeah, well, actually, what you would have picked up here is that if you'd have given my nan a mobile phone and said, right, okay, you've had a mastectomy, you want to understand, how you're feeling, how your outcomes are, just, simply behavioural messaging, and we'd have picked up, actually, she was depressed. Yeah. There's this glamorous lady who's had a single mastectomy, and actually it impacted her horrendously in terms of just her outgoingness, yeah, how she could, be seen in public. Yeah, she lost all confidence. And if you'd have then had the ingestible sensor picking up that, different pattern in terms of behaviour, physiological behaviour, you'd have painted this picture of this lady that actually, when her grandchildren went to primary school, went to high school, that actually, she pretty much gave up. She gave up going out, she gave up going socialising, she just was not active anymore. She wasn't really happy. So what could we have done? Okay, so that's the question, what could we do? So this girl gives us a signal, but then what can we do? Well, in the same way, we could have said, right, okay, we understand that, you're a little bit depressed. We understand that you're becoming overweight. We understand that actually you're becoming more sedentary in terms of your lifestyle. So what we're going to do is we're going to profile you. We're going to use psychological profiling to understand what motivates you. Yeah, so we're going to start with a health psychology approach, and we're going to push behavioural messaging to you that's going to resonate with you. It might not resonate with somebody else, but it's going to resonate with you, and we're going to motivate you through digital health. We're going to then set you goals, daily targets. Walk into the garden gate, doing some gardening, going to the shops for a change, And we're going to capture how you're feeling about these daily targets, but I'm going to agree them with you as the patient, and we're going to set them. And in fact, what we're going to do is we're going to monitor activity. So we're going to give you a Bluetooth pedometer or a Fitbit or a wearable to measure that activity. And then we're going to give you scales because you're morbidly obese and we want to see that weight reduce. And all of this could be reported back to the physician, to make sure that actually, she's maintaining those goals. Lifestyle management. We're going to push her content as well around what she should eat, what she should cut, etc. So a lot could be done different. Next part in terms of when she fell in 2012 and she ended up in hospital for 3 weeks. Pretty much, up until this point, she lived downstairs in her armchair, watching snooker. She would have loved Wimbledon. But in 2012, when she fell, when she got discharged out of hospital, we decorated a bedroom. She kind of, had some bed rest, and she never really went downstairs again. She used to walk across the landing to the toilet. We got carers in, we looked after her, but she literally just gave up. And in fact, not only did she give up, but the NHS pretty much discharged her altogether. The NHS gave up on her, There's this, 78-year-old lady who'd had a fall, morbidly obese, discharged, that was it. But why was that it? Okay, she was housebound and it's difficult in terms of resourcing, in terms of treating people in the community. But what I put to you is that 90% of all consultations in the National Health Service are face-to-face. If we could reduce face-to-face consultations by 1%, we would save £200 million. So there's a huge opportunity cost to becoming more efficient and adopting technology to drive consultations. So why could she not have been given a virtual consultation to check up on her, see how she was? In fact, why couldn't she be pushed a rehabilitation programme? An exercise, give an exercise video, so she could have rehabilitated while she's at home. Why couldn't a carer's been given that? My mum, my uncle, me, so we could have supported her better. So there's lots we could have done, and we could have pulled PROs to make sure actually she wasn't bedbound. If she'd have had a pedometer, if she was on the Proteus pill, you would have seen that she wasn't leaving bed if you were a healthcare professional. There would have been alerts. So I said before that I suspected that she had COPD, and I guess I suspected it from my adult life in the fact that she was always wheezy. She smoked 20 cigarettes a day. She was always out of breath. She struggled doing things in a later life, which wasn't more physical, but she used to have to sit down and catch her breath. And there's an app called SpiroSmart, and it actually has algorithms that can essentially, hopefully, detect and pick up patients' FEV1. And actually, as they're testing it as a diagnosis for COPD. So simply by using the microphone and blowing into the microphone, hopefully can pick up whether you've got COPD or not. So had she been prescribed this, actually, first and foremost, had she been risk stratified using the EMR data on the GP database to flag that actually she smokes 20 cigarettes a day, she's over the age of 40. If we'd applied national health policy to her, she would have been classed as the missing millions. Then she could be prescribed the SpiroSmart on a smartphone. My nan had a smartphone, she had an iPad. They would have been able to pick up whether she had COPD. Or even better, would have been picked up the reversibility, lack of reversibility, and picked up a lung cancer a lot earlier. And then they could have given her literally a vital sign monitoring. So you've got the Scando Scout, which you literally just hold it to your head, and it picks up your oxygen shots, your temperature, your BP, your respiratory rate, heart rate, etc. So there's lots in terms of vital sign monitoring. We could have picked up that cancer a lot sooner. But what I put to you is that, and if George Freeman was here, or Simon Stevens was here from DH, they talked to you about combinatorial innovation. Because whilst I can kind of say, I wish this would have happened, I wish, we'd adopt digital health for patients like Manan in the future, that actually not one intervention here, I believe, would make a big difference. It's a combinatorial approach. And when we're trying to translate and understand how medicines get adopted or how our technologies get adopted in a pathway, clinical pathway, unfortunately, they're not silver bullets. We have to think about how we can collaborate. Where else do we support the pathway? Where else do we support the patient? Where else do we support the physician? And actually, if you can imagine the amount of data all of these things would have created, we could have created dashboards, alert-based systems. We could have used computational and predictive modelling to understand treatment and disease progression. So there's a lot of things we can do. And really, when I think about the healthcare challenges that global healthcare and governments are facing in terms of managing patients with long-term conditions, multiple comorbidities, ageing populations, unless we adopt technology-enabled care, we're going to be struggling. Thank you.